All right. Well, we're going to go ahead and get started. Welcome to the Epilepsy Foundation of Connecticut, Ask the Expert. Each month we try and focus a topic related to epilepsy. I'm the Director of Programs and Services at the Epilepsy Foundation, and I'm going to be moderating tonight's presentation. Our mission at the foundation and nationwide, the foundation's mission is to support people that are impacted by epilepsy through advocacy, education, programs, and connections to ensure that they can live their best lives. So tonight we're going to be discussing genetics and epilepsy. Our presenter will be talking about indications of genetic testing in epilepsy, along with limitations of genetic testing, followed by the role of precision medicine to treat epilepsy, and then future directions. There's going to be time for questions and discussion at the end of the presentation tonight. And the doctor's happy to answer questions concerning the topic, but we ask that you try to keep them as general as possible. So with that being said, I'm going to introduce our speaker for tonight. We have with us, let me advance my slide here. Oh boy. I didn't check. Okay, hold on one second, everyone. I apologize.
Monica, if you have trouble advancing, I'm happy to introduce myself. No worries.
Okay. Well, yes, okay. Well, I don't want you to have to.
No
Let
problem.
me stop sharing and then I'll introduce you and then you can share your own slides. So we're joined tonight, I apologize, with Dr. Singh. Dr. Singh went to medical school in India, and she is an adult where she was an adult neuro residency and did 2 years fellowship from NYU Langone. She was on the faculty at NYU, Mount Sinai, New York, from 2002 to 2024. She did move to Connecticut and joined Yale just about a year ago in 2024, September. Dr. Singh recently joined our professional advisory board. She's also a professor and triple board certified in neurology, clinical neurophysiology, and epilepsy. And she's the director and clinical chief of the Yale Epilepsy Center. And she also, lastly, co-directs the epilepsy surgical program at Yale. So we're very pleased to have her joining us here tonight, and I will hand it over to Dr. Singh.
Thank you, Monica. I'm happy to be here. Are you guys able to hear me properly and see my slides?
Yes.
Okay, thank you, Monica. So I moved to Yale back in September 2024 and worked at NYU as well as Mount Sinai, two institutions in New York. Happy to be here at Yale. Very grateful to the Epilepsy Foundation of Connecticut, who gave me a chance to become the to be a member of the professional advisory board. We'll definitely do a lot of outreach program with their help. Because I really share the vision of the Epilepsy Foundation, how to improve the patient experience, how to give accessibility to people who are underprivileged, underinsured, or looking for some answers to treat their epilepsy. With that intro, I've been given the task of discussing genetics and epilepsy. My full disclosure that I'm not a genetic counselor. I do not have any special training in genetics. But as we understand the era of genetics, where we order more and more tests to find out what we used to call unknown reasons for epilepsy. And I'll go through my slides and explain you what do I mean. So epilepsy is a common condition. It affects about 1% of the general population. At least 1 in 10 people will have a seizure in their lifetime, but at least 1 in 26 will have epilepsy. So what is a seizure? What is epilepsy? Very briefly, seizure is a change in the clinical manifestation of the patient as a result of too much excitation in the brain, which is a transient phenomena, and depends on where the seizure starts. The clinical manifestation of the seizures may differ from patient to patient. Seizures can be provoked or unprovoked. Provoked seizure means that somebody had a low blood glucose or had some wacky electrolytes in their body and had a seizure. Those patients do not need to be treated with an anti-seizure medicine. On the other hand, if somebody had one seizure and had some abnormal testing, like if the MRI was abnormal, if the EEG was abnormal, they will have a higher chance of recurrence of a second seizure. So those patients get put on anti-seizure medicine. And it all depends like what are the risk factors for epilepsy and who will remain on these medications lifelong versus we will attempt to wean them off certain medications after a few years of seizure freedom. Because of the risk of associated injuries with epilepsy, each case is taken individually, and you cannot generalize that if patients ask that after how many years I will come off the medication, and that's a very difficult question to answer if somebody is driving to work or doesn't want any injuries in front of 100 employees that they are in their office, people, CEO, they don't want to have a seizure in front of 100 employees. So it really depends from case to case. Sometimes an elderly patient who is in a nursing home, even if they have a recurrence of seizures because we took wrong decisions about that case, will probably not get hurt in their own bed. So each case is different. And every time we see a patient, we try to discuss those risk versus benefits, risk of keeping them on medication and benefits of, you know, risk of seizure occurrence as we withdraw the medication and the benefits of like protection against future seizures. And I'll briefly discuss that what is the role of genetics, where does genetics play a role here? So if you see this pie chart, most of this epilepsy is idiopathic, that we do not find the reason why somebody has epilepsy. But some of the risk factors for epilepsy, if somebody has a head trauma with loss of consciousness, if somebody had a vascular lesion in the brain or a brain tumor or a stroke, or they develop some kind of an infection of the brain like meningitis or encephalitis, or they were born with some congenital problem, like, they were born with some neuronal migrational disorder or something, that their brain cells were not laid out properly. If they suffered from any anoxic injury at the time of the birth, but most of the epilepsies, we don't find a cause, and that comes up in patients' discussion. Dr. Singh, why do I have epilepsy? You are telling me that the MRI of the brain is normal. My EEG is normal. Why should I go on this medication? So we try to find out the cause by doing more and more sensitive MRIs of the brain, looking for any abnormality, assessing the risk factors. There are certain epilepsies which are related to autoimmune condition. So these patients will have several other family members who will have autoimmune diseases. And in those cases, we usually send an autoimmune panel. And we try to look really hard for any lesion in the brain. Some lesions are so subtle that they need advanced imaging to be able to localize it. If medications are successful, so 2/3 of the patients will be controlled, reasonably well, and probably they will tolerate the medication side effects too. So they don't have any impairment of quality of life, and they are dealing with their epilepsy, and they don't have to go through, big epilepsy centers or go through epilepsy surgery. But 1/3 of the patients remain refractory to any medical treatment. So if somebody has a lesion in the brain, you can resect it, or you can neuromodulate the brain to help their epilepsy. But most of the epilepsy patients where we could not find a cause, we are realizing with time that most of them, or some of them, a good percentage, is as a result of mutations in the chromosomes. And, when I did my training, there were like really handful number of genes which were implicated with drug-resistant epilepsy, maybe 8 to 10, and that has gone to up to 900. So there are different multiple gene panels that you can do to assess that what kind of mutation they have. So here I'll try to explain the basics of genetics. So what is our genotype? So Watson and Crick won the Nobel Prize by describing this, what we call DNA, deoxyribonucleic acid, which has the genetic code. And how we express whether I have brown eyes versus brown hair, or, extra toe in my foot, that determines, that's called the phenotype. So genotype is the very unique sequence of DNA that we are born with. But what facial features I have, what color of the hair, what, you name it, different things, that's my phenotype. So any physical or biochemical characteristics of my body is referred to as phenotype. It definitely has impact from the environment. If I'm drinking a cup of, if I'm drinking water from a plastic bottle, or I'm exposed to some pesticides, definitely environment has a has a role to play, I'm sorry, has a role to play to modify those genes. But that's called a genotype and a phenotype. Now we know that our body is made of cells. We have about 10 trillion cells in our body. Each cell has a nucleus where we have this material called the DNA. And that DNA is about, in each nucleus is about 1.8 meters of DNA, which is folded in this double-stranded structure. But then it kind of unfolds itself and does some modification in the nucleus, then leaves the nucleus, goes to somewhere else, and makes what we call proteins, right? So there are amino acids, which are like 3-letter words, base pairs, and that the way they get arranged into a big chain, which is right here, called a nucleotide, the way it folds into different shapes, that's called proteins. So there is a process called transcription when you're copying the genetic code from this DNA and transforming into an mRNA, release of this messenger RNA, which goes to 2 different other types of ribosomal RNA and transfer RNA, different kinds of RNAs, which assist making this, nucleotide and this thing, which is called proteins. And those proteins are important for, making different enzymes, which are important for all kind of metabolic reactions, whether I'm, metabolizing my fats or carbohydrates or my proteins, they will have a role to play. So whatever physiology happening in our body is as a result of these proteins. So if anything goes wrong here, if there is any mutation happens, which can happen at a single cell level, right, when you were born, before the fusion of even the sperm or the egg, or it can happen when the zygote is formed, when the sperm and the egg, they meet with each other. And then, you go from 2 cell to 4 cell to 16 cell, and, that multiplication. Similarly, when this process is happening, it's constantly, the speed with which it is multiplying is just phenomenal. If you look at the YouTube videos of how the translation and transcription happens, and the speed with which these proteins are made is just phenomenal. Now, people get confused about what are genes and what are alleles, and I'll try to simplify it. But before I simplify it, let me show you the same diagram again. So we have this double-stranded DNA. It is becoming what is called a precursor of the messenger RNA, which is going to make our proteins. It's going to become a single-stranded messenger RNA. Then it is going to go out of the nucleus into the cytoplasm, get attached to some other kind of RNAs, and will start making these nucleotides or peptides, which are going to fold in a certain way. And if anything goes wrong with that process as a result of the genetic mutation, some people are more prone to have or propensity to have seizures. So then, what are genes and what are alleles? It's going into the nitty-gritty of it, but genes are chunks of DNA. But where in the DNA things are located and have a certain trait is called alleles. So suppose genes is one kind of a recipe for, say, eye color. And my father has brown eyes and my mother has brown eyes, but they will give me one little allele, and the combination of the two alleles will determine that whether I will have brown eyes or will I end up with the blue eyes. So we inherit one allele from each of our parents. Now, the genetic material has about 4 pairs of these, this is our DNA made of these different adenine, thymine, cytosine, and guanine. You don't need to know this. But with these 4, if you multiply, if the codon, the genetic codon is only 3 base pair, you can have 64 different combinations. But you have only 20 amino acids which are going to make protein. So where did nature go wrong if there were only 61 codes for these 20 amino acids? Nature usually doesn't go wrong. So there are 3 codes which will stop making the gene, making the protein, which are called stop codons. So mutation is defined as if there is any error in a DNA code. Now that error may be lethal, or that error is something which is very neutral and very silent and will have zero effect on the development of or the production of the proteins or enzymes. So in this human genome, which is double-stranded, there are some areas which are going to code, and there are some areas which are not that important, called non-coding regions. So the coding regions are the ones which get transmitted through my parents to my different cells. So it's the exons which are important. And if you look at the structure of the DNA, the exons are only 1 to 2%. And this is a good, cartoon to show that we have exons and we have introns. Introns are not going to get transmitted. Exons are going to get transmitted. So majority of the mutations that we have, they are usually neutral, and we all have mutated DNA, but mutations can occur at a large scale or a very small scale. If they are at a small scale and they are silent, we don't worry about it. But if they are at a large scale and really modify the structure of the proteins, then whether those cells will be very hyperexcitable and cause seizures and will not know how to stop seizures because they are not putting enough inhibition when the seizure is happening. So usually brain has a very good braking system to stop the seizure. But some patients, why do they go into cluster of seizures or have seizures which doesn't stop for more than, say, 2-3 minutes? Why do some people are prone to more prolonged seizures? Is because that inhibition is not is not the way it should be. So these are some of the examples of the genetic mutation. So suppose it's a 3 base pair kind of a code, cytosine. You don't need to really know these names, but I wanted to show you that if this is the normal gene, you can have some kind of a mutation which causes this duplication, B is repeated twice. You can have a mutation where instead of A, B, C, it just becomes A and C. So there are sometimes we have deletions. Sometimes the whole sequence get inverted. That's called inversion. Or sometimes it just locates in a different location called translocation. So there can be some mutations which are very silent, If this was supposed to make this amino acids, it's still making the same amino acids, though it's slightly mutated. But there are some mutations which, if the order is changed, they will make a different amino acid that may affect the body function, may not affect the body function. Sometimes we have what we call nonsense mutations that, it's not compatible and it says, no, stop making the nucleotide, stop making that chain, stop making that protein. So there are different kinds of mutations that we come across. Now, this is that famous Punnett square that it's a good square to explain how the genes come from the mom and the dad. And if somebody is presenting as an uppercase A, that means it's a dominant gene. And if that is present, it is going to have a lot of say that make the color of the eyes brown for my baby. If you have a small lowercase a, it may have little say or no say unless you are acquiring 2 copies of that gene. So each square is representing 25% chance of whether you will be born with the brown eyes or a blue eye. If you have a dominant gene, even if one is present from one parent, you will still have brown eyes. Again, a dominant A still have brown eyes, but once you lose that dominant A, then you will have blue eyes, right? So people ask that what are the chances that I would give my epilepsy to my child? And people have genuine fears about it. I saw a patient at Bellevue in New York City who literally kissed my hand when I told her that it's okay to get pregnant. Yes, I understand you have epilepsy, but you will be a wonderful mother. So she was told by one of the neurologists in New York City, forget about having children. Forget about being a mother. You will not be able to take care of your children because of your epilepsy. And unfortunately, she was reaching in her 40s. And by the time she conceived, she had an abortion. And then she, broke up with her boyfriend. But, people are so misinformed about, epilepsy. And people have fears about transmitting it to their children. So women will get pregnant. We'll have a session next month or the following month on pregnancy and epilepsy. But this question comes up all the time that what are the chances that I will transmit it to my kid? It depends on what kind of epilepsies we have. So some epilepsies are earlier in onset. They tend to they get transmitted to the children more often. But there are so many different types of epilepsies, and some have less chance of transmission versus some have more chance of transmission. And that's the reason people want to know that what are my chances? Can I go for genetic testing to find out that, what are my chances that I'll transmit it to my babies? So there are different kinds of gene mutation. One is called that only single gene is responsible, got mutated, and will cause a certain kind of disease. And it really doesn't follow the rules of what we know, or you must have studied in science, Mendelian laws of inheritance. That if you have a dominant gene, you have one dominant gene, you have a 25% chance, like what I was showing here. If you have two recessive genes, you have only 25% chance of transmitting it to your baby. If you have a dominant gene, then you have a 50% chance of. So the epilepsy somehow doesn't follow those rules, in largely speaking. And then it's usually more polygenic, multiple genes are involved to cause that kind of a complex inheritance. But there are a lot of spontaneous mutations which are called totally new occurrences, also de novo mutations which happen. And there are other factors which are environmental factors that I mentioned. Like people have traumatic brain injury, people have stroke, but not everyone with traumatic brain injury will develop epilepsy. Not everyone post-stroke will have epilepsy. Can we somehow determine that what genetic mutation will predispose them to have a post-stroke or post-traumatic epilepsy? And can we treat them empirically, or try to prognosticate them that you have a higher chance of having post-stroke epilepsy? Maybe you should take a little bit of anti-seizure medicine before you even have the first onset seizure. Usually we don't do that. If somebody has a brain tumor or somebody had traumatic brain injury, but there is no history of seizure, we do not empirically treat them. But if they have certain mutations and we know that their chances of having those post-stroke, tumor-associated epilepsy or TBI, associated epilepsy, should we treat them or not treat them? There has been, as I mentioned before, that before we used to concentrate on different types of channels in the cells, but there has been a tremendous knowledge about different types of mutations which get involved in causing epilepsy. So the main question is that who should be tested? The first thing that crosses my mind is if patient is doing well, if patient is intellectually normal, and you're not dealing with refractory epilepsy, probably the yield is so low that you're not, even if you send send them to a geneticist and get the genetic panel, which is always, questionable whether insurance is not going to pay for it or not. But if you have unexplained epilepsy where you were looking for a cause, if you're looking for an MRI which did not show any abnormality, if the EEG did not explain anything, or if you saw some features on the EEG which make you think that this may have some genetic significance, so any unexplained epilepsy should go to a geneticist. And it's regardless of age. Like I'm an adult epileptologist. I see patients as an adult. Usually pediatric epileptologists will send patients for genetic testing much more than the adult epileptologists, but it's really the current recommendations are that anybody who has unexplained epilepsy, regardless of age, should have genetic testing. When patients have this query that, what are the chances of my children inheriting the disease, those people should be referred to a geneticist. Anytime I find any mild intellectual disability or some kind of an autistic features, even mild forms, I think those patients should be tested because patients with autism have a higher incidence of having epilepsy. Whenever you see that there are abnormal physical features, somebody with a very small head, somebody with an extra digit, or anything, any dysmorphic features, anything abnormal, or when you're seeing that there are a lot of organs involved, like there are lots and lots of multiple congenital birth defect, is it because of some kind of a chromosomal abnormality? Anybody who has delayed milestones, they started speaking late, they started walking late, those patients, if they have epilepsy, should be sent to a geneticist. If you have a very strong family history, like febrile convulsions associated with fever, so why only few children who have high fever will have a seizure while the rest of the world who has fever will not have a fever-associated seizures? And if you have a very strong family history of febrile seizures, means seizures presenting between 4 months of age to 12 months of age, those patients should have some kind of a genetic testing. If patients are not doing well, why do they have drug-resistant epilepsy? We are giving them the medication, but maybe the medications are not reaching the areas in the brain where it is supposed to act. So is there any mutation there which is causing some kind of a transporter defect that enough medicine is not going there? We try to treat cancer with chemotherapy. Is there some kind of a transporter mechanism that is not causing that chemotherapy to act? Same is the story with the epilepsy. So those are some of the cases There are certain conditions which are progressive. Like a good example is some people have this condition called progressive myoclonic epilepsy, where not only they have some muscle twitches called myoclonic seizures, but they also have grand mal seizures, but they also have certain deterioration. Cognitively, they are deteriorating, or their balance is not the same as it used to be when they were young. So those patients will have different kind of a testing that is needed to assess that does this patient belong to that particular kind of epilepsies. So these are different common indications for genetic testing, and it boils down to the same thing. Autism features, if there is some kind of a progressive diseases called in pediatric population, these are referred to as epileptic encephalopathy. If there are epilepsies which run in the family, those patients should have genetic testing. And if patients are not doing well, then they will have a higher yield. Some of the drug-resistant epilepsy patients are at a higher risk of, unfortunately, what we call sudden unexplained death in epilepsy. And is it because of some mutation in certain kind of genes, which is determining why do they have drug-resistant epilepsy? And is there any medication that we should stay away in those particular cases to avoid the risk of sudden unexplained death in epilepsy? I think that can be determined by making sure that they don't have a mutation, which can help us figuring it out that what will be the best medication for this kind of patient. So we did talk about these different kind of mutations like deletions, duplications, insertion, inversion. Sometimes the whole reading frame of the messenger RNA is messed up because of these mutations. And those are called big frame shift mutations. Sometimes there are some nucleotides which are repeating too many compared to what a normal nucleotide should look like. So those patients will have different kinds of epilepsy, and they fall into certain kind of epilepsy syndrome, which helps us prognosticate how well these patients are going to do, or do they need what we call just supportive therapy. These are the common mutations associated with epilepsy. Some of them are associated with sodium channels, some with potassium channels. Some are very peculiar, and the medications do not do much for those patients. But if you treat them with certain kind of diet, then they will have a miraculous recovery, miraculous control of their seizures. And one such example is what we call GLUT1 deficiency. So our brain is dependent on glucose, right? So, but the blood glucose needs to reach the brain, and these patients will have some transport defect in transportation of the glucose from blood to the brain. They don't respond to any other anti-seizure medicine, but they respond beautifully to ketogenic diet, which is a special diet which is rich in fats and very low in carbohydrates. There are many new syndromes that have been identified, which have, they respond beautifully to one medication other than the rest of the anti-seizure medicine. So why waste 20, 30 years of their life trying to switch from one anti-seizure medicine to another, and then figuring it out that they have this mutation and this will act better than the rest of the medicine. That's why I'm bringing you these common mutations associated with epilepsy, which if we do the genetic panel, these can be identified. Like, for example, this mutation is associated with what we call Rett syndrome, which is associated with severe mental retardation. And patients it's more common in females, but they just keep rubbing their hands and they have terrible, terrible epilepsy. People who have this kind of pathway mutation, they respond beautifully to certain drugs, which I'm going to show you in next slide or the following slide. So these are different epilepsies which are just dependent on one gene mutation, and that's why it's called monogenic epilepsy. Probably this is the one which is very common, called SCNA1A gene. And these patients are more prone to status epilepticus. They will have seizures with high fever as an infant, and they will have poor development. But more and more, drugs are in the pipeline to see that should we concentrate on sodium channels? Should we concentrate on potassium channels? How do we treat epilepsy? There are certain medications which respond beautifully. Patients respond beautifully if you put them on something like Sabril. It's a drug that is used for a condition called tuberous sclerosis, where you have lots and lots of potato-like tumors in the brain called tuberous sclerosis, again associated with autism and intractable epilepsy. Almost 80% of the patients are, they have autism and, delays. So all these mutations were not known to me, at least when I was doing my residency. But now they have, the support groups. They have different kind of alliances to discuss that. Okay, which medication worked for your child? Maybe I should tell my doctor that maybe try that medicine. So that's the whole beauty of putting all these patients and families together in support groups, something that Epilepsy Foundation of Connecticut does, and trying to help those families to get answers that why their epilepsy is not controlled. In the interest of time, I'll just mention few things on Dravet syndrome. There are certain medications which make this epilepsy worse, like Lamictal or oxcarbazepine or carbamazepine. And if these patients are at a higher risk of sudden unexplained death in epilepsy. So it's very important for people to know that, okay, this epilepsy is caused by this kind of mutation, and I'm not going to use lamotrigine for this patient. And I'm going to explain the families that there is a risk of sudden unexplained death so that they know what to do or how to prevent this kind of an unfortunate incident, people dying during seizures. Similarly, this is another deficiency syndrome for which we have the CDKL5 alliance, but these are the patients who are 90% of them are girls, and they die within a few months or so. It starts at a certain age. It has certain types of seizures, and these children cannot walk, talk, or feed themselves. So very dependent on everyone. And some sodium channel blockers work really beautifully with this drug, with this kind of condition. Similarly, there are some benign epilepsies which are associated with potassium channel mutations. Some have very, very limited seizures. They start at a very early as a neonate, and they stop at a certain age in neonates, versus some other who have terrible epilepsy and different kinds of seizures, horrible EEG background, and very poor prognosis. So I think parents are entitled to know, will my child belong to the benign category, or will my child belong to the severe or catastrophic kind of epilepsy? The common samples that we take for genetic testing these days, it's not invasive. When I was a resident, people used to take skin biopsy and look for mutations. But I think the field of genetics has grown so quickly and so widely that usually people will either have a blood sample or they will have a saliva sample. In a saliva sample, either you spit in a tube, the saliva gets collected, or you take a swab and you use it in your buccal areas, and you give the saliva kind of a sample. There are different types of genetic testing, and question comes up that what is the best kind? So the best kind, I would say, is let's read the whole genome, read the whole chromosomal genome. We talked about that there are certain introns and exons, so you can do the whole exome sequencing where you're just doing the reading frame, the coding regions, which should determine what mutation is going to get transmitted. But these tests are not available to everyone. Insurance denied to cover the cost of these. So people do something like chromosomal karyotyping. Like if somebody has Down syndrome, you can look at all the 46 chromosomes and see which chromosome is deleted, which is not. Or you can look for something in between, which is called a multiple gene panel. It depends whether you're going to send a panel which is going to look for 25 genes, or you're going to send something larger. So if you look for smaller number of genes, the yield of positivity is less versus longer, more number of genes. So if this is a normal human, chromosome arranged in 23 pairs of these 46 chromosome, and X and Y determining that whether we are male or female, you can sometimes look for like Down syndrome doesn't have this pair. It has these 21, 3 pairs instead of 2 pairs at chromosome 21. So the chromosomal karyotyping can help. Or, there may be some deletions that part of this is missing. And these are the 2 syndromes that are very commonly associated with refractory epilepsy or drug-resistant epilepsy. This one acquired from the father, this one acquired from the mother, but the same chromosome. So in those kind of conditions, when you have a phenotype that you're thinking about this particular condition, you can do chromosomal karyotype, but it's not important. It's not it doesn't work for patients who have very small changes in their chromosomal, you know, in their chromosomes. If there are very small deletions or very small duplications, it is not going to show up on that very gross test where you're doing the karyotyping. So usually when I get the results back, either they say it's benign variant, it's not going to do any harm. Sometimes they're not that sure. They say likely it's benign. Sometimes they're very, they know that this mutation is pathogenic or likely pathogenic. But the most common results that we get is what we call variant of uncertain significance. That so far we have not identified any other person in this world who has this genetic mutation, but the field of genetics or the genetic knowledge is growing. So maybe come back 1 year later or 2 years later and try to see if there is any significance, or maybe get your father tested, get your mother tested, see if they have any kind of mutation, which will make sense that or will guide us more, or will learn more from that kind of a sampling from your mother and father to understand your condition. Precision medicine is like which medicine you're going to use for what kind of condition. And as I mentioned before, there are some options for certain kind of different syndromes, like Dravet syndrome, the one that we said is associated with febrile seizure and status epilepticus. Several studies have shown that the CBD, the medicinal form of marijuana, works really well for those patients. And some other new drugs that came out are also the drug of choices for that kind of a Dravet syndrome. This is something that was not known, 5 or 6 years ago, that there is a thing called precision medicine where you can say, okay, we found the mutation, we are going to treat my patient with this particular medicine. And this is my last slide where I'm just going to talk to you about that the diagnostic yield of different tests that we send is different. So for chromosomal analysis that I showed, like for Down syndrome, it's very low, but the yield becomes higher and higher when you're doing the exon sequencing versus if you're really reading the whole genome, which is 48% versus with the exon sequencing whole, it's 45%. I want to thank everyone who stayed for this conference. If you guys have any questions, I know Monica is going to help me. I would love to take, this opportunity to mention that, we have at Yale the geneticist available. I remember one of my patients, she was already going for a surgery, and she had this structural abnormality on her brain MRI called the periventricular nodular heterotopias. And, most of the physicians would not send the patient for genetic testing. But as I was reading more about that condition, I came across some mutation. So I said, let me just get my patient tested for this mutation. She had epilepsy for a long, long time. And just before she was going for this surgery, the geneticist, like maybe 2 weeks prior to surgery, told me that sometimes this mutation can be associated with heart abnormalities. So before going for any surgery, I said, let's just do an echocardiogram and an EKG. We would have done the EKG anyway, but echocardiogram to make sure she doesn't have that abnormality. It's not affecting several organs in the body. And thank God she didn't have any cardiac or heart related issues. But it just makes us think more about that. Is there anything, is this mutation associated with renal cancer, kidney cancer, or liver cancer? Should I screen my patients and do more of a screening kind of test to assess his or her risk factors? I'm going to stop sharing here. Also, I wanted to say that in April, is that right? In May, we are doing pregnancy with epilepsy. So,
Yes, that's correct. Yeah.
any questions?
Yeah, so if anyone does have questions, please type them in the chat and I'll go ahead and read them. Dr. Singh, I don't think any of us would have known that you were not an expert on this topic because that was that was really great. And my understanding from what you shared at the beginning of the presentation, that it sounds like even though most of the epilepsy population, the diagnosis may not be known, but from what you were saying, is it possible that I don't know, whatever 70% of the population, maybe there is a genetic cause that perhaps has not been discovered yet?
Yes, absolutely. I mean,
Mm,
that pie that I showed you, most of it is coming as some mutation. But I
mm,
think the art of this practice is also like, if my patient has this mutation, can I connect to the group who is an expert in that, like CDLK5 deficiency, right? That they have seen that one medication works better than them, or some medication makes the seizure
mm.
worse. So.
One question is asking who are the people who tend to develop epilepsy after head trauma?
Right. So, as I mentioned, that not everyone with head trauma will have a post-traumatic brain injury.
Mhm.
Usually, trivial head traumas, we bang our heads against the shelf, multiple times. But if there is a loss of consciousness, if people are in a prolonged coma, those patients are at a higher risk of developing post-traumatic brain injury. If there are any penetrating injuries in the skull, like, some kind of a skull fracture, or there is any kind of a blood collection in any compartment in the brain, whether it's in the deep in the brain or it's more superficial, where people had to literally drain the blood, or it was, blood was so little that it was treated conservatively. So if there are any penetration of the coverings of the brain, if there is any blood in the brain, or if there is a prolonged loss of consciousness. And it's all arbitrary that people say that if there was a loss of consciousness for more than 30 minutes, usually those patients are at a higher risk. But again, post-traumatic epilepsy, it's, people can have seizure at the time of the scene when they had an accident and a loss of consciousness, but they can have early post-traumatic seizures or late post-traumatic seizure. Early means that they will have another seizure within 1 week after they had a trauma, or late is it can be days to weeks to months to years, because there is a process that happens in the brain after any inciting brain injury, like what we call kindling effect. It takes time for the brain cells to kindle and make these epileptic circuits as a result of that traumatic brain injury. So it differs, but usually I would say It depends on whether you had mild, moderate, or severe traumatic brain injury. What was your level of consciousness at the time when you presented at the hospital? And you go from there. If it was a severe TBI, then I would say 20 to 30% may have. Versus if it was a very mild TBI, I would say I would quote something like 6 to 7% may have post-traumatic epilepsy.
But that isn't necessarily like the cause of the genetics is not necessarily the cause of
It
post-traumatic
is, it
epilepsy.
is. No, it is. It is
It
really
is?
that people who have mutations in certain kind of mutations, they will are at a higher risk of post-stroke epilepsy or post-TBI epilepsy. This is
Mm,
something like not everybody who has a
okay.
fever will have a seizure. It's one of those things that is there anything
Wow.
in our genes which predisposes us to have a febrile seizure or post-stroke epilepsy. But more work needs to be done on that.
Yeah, which explains then, like you said, why some people will develop epilepsy when after a TBI, and then why some will not.
Yeah, yeah.
Mm, okay. And here's a good question. So, what percentage of your patients do you usually recommend for genetic testing?
More and more as I'm learning all these syndromes more and more about
Yeah.
different mutations causing epilepsy. I am if they are doing very well, if intellectually they are okay, then I said the yield will be very low. But if they are drug refractory and they have any intellectual issues or anything like autism or other things, or I find that there's multi-organ involvement, some abnormal facial features, I send them to a geneticist. I think the best way to interpret these results is somebody who has a deep knowledge of it, because then they will do the pre-testing counseling and the post-testing counseling to see the relevance of what I described to you guys, like variant of unknown significance. They will deep dive into figuring it out that what is the relevance. Does this patient need to repeat this study? Maybe we will know that mutation, the significance 2 years from now, which is not available right now. So people say 1 year, 2 years, they should have the repeat testing if they're not doing well. We're also accumulating the mutation analysis of the tissue that we get from the patients who underwent epilepsy surgery to see if we find certain genetic mutations to help us better understand who have refractory epilepsy.
And is it correct to say that all genetic causes of epilepsy are hereditary?
No, not all are hereditary. Some are
Okay.
spontaneous mutations, what we call
Okay.
totally new occurrence or de novo mutations.
Okay.
That can be at a very early stage, but usually it is after the zygote is formed with the fusion of the sperm and the egg.
Hmm. And it looks like we have one more question. Is there a way to determine the risk for a baby before birth having epilepsy other than genetic testing?
Yeah, so they do what we call amniocentesis and chorionic villus sampling to look for mutation. Usually Down syndrome, I'll give you an example, gets diagnosed beforehand in most of the cases with our prenatal screening. So yes, if there is a high risk patient family, that it can be prenatally determined by doing the amniocentesis, looking for the in the amniotic fluid, or by doing repetitive ultrasounds. Like sometimes abnormalities in the brain and the spinal cord are quite evident on repetitive ultrasounds. Uh, but if few diseases run in the family, epilepsies run in the family, it can be, not all diseases can be diagnosed prenatally, but some can be.
And I think you answered this question at the beginning, just as far as with like the chromosomes and the genes that I guess we're getting from our parents when we're born. But why would one sibling get epilepsy and then not the other sibling?
Probably because of the changes in, like, suppose somebody has a monozygote, identical twins. one goes to Harvard and is doing very well, and other is dealing with this epilepsy, probably the mutation occurred at some kind of a de novo mutation, new mutation occurred because they should have exactly the same copies if they are identical twins. So mutations can occur at any level. It doesn't have to be totally transmitted from the parents.
Mm. But even if it's not a twin, if I guess if your type of epilepsy is hereditary but your sister or brother doesn't get it, it's the same response or explanation that you just gave.
Yeah, it's the explanation that I just gave. That is usually the spontaneous de novo mutation, probably intertwined with the environmental that we are exposed to.
Yeah. Oh, interesting. Well, thank you so much, Dr. Singh, for this. And this has been recorded so people can listen to it again. I know it's a lot of information to take in a short period of time. Certainly, if you have questions that maybe we can help, kind of get the answers for you with Dr. Singh and even through other doctors in the community, let us know. Of course, your doctor is a good one to go to as well if you have further questions about the topic. As Dr. Singh mentioned, she will also be covering pregnancy as it relates to women with epilepsy in April, or I'm sorry, in May. So we're in March, so this one will be in May.
Yes. Well, thanks for joining us. Bye-bye. Have a
Yeah,
good.
thank you all. Bye.
Thanks, Monica, for arranging this.
You're welcome. Thank you, Dr. Singh.
Bye-bye.